Welcome to the show, Your Healthcare. I'm Dr. Amit Lahav, and in this show we discuss medical topics and related issues. Today we'll discuss actually a very important topic, back pain. How many of you out there have had back pain? Oh, know somebody who's had back pain. About 8 out of 10 people will have back pain throughout their life at some point. Then we'll also discuss something that's been around now for a little while, but it's really been coming out of the woodwork, and that's some topical pain management, some topical creams or different type of gels that can make a different effect and relief that you may have instead of taking oral type of medications. This topical type of treatment is sort of new, and I want to kind of bring you up to date on what's available out there and some of the stuff that I personally use and choose. We'll have a very lovely guest today, Miss Ashley Doran, who will help me illustrate a little bit about back pain. I'll give you some pointers of as an orthopedic surgeon, what do we look for when there is back pain? And Ashley will be a very valuable asset for today's show. This is Your Healthcare. I'm Dr. Amit Lahav, and stay tuned. We'll be right back to speak about back pain and some topical pain management. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and I'd like to start the show today discussing back pain. And first of all, I want to introduce my lovely guest today, Miss Ashley Doran. Thank you very much for being with us here today.
No problem.
Now, we've worked together now for a while, so you've been in the medical field now for a little while as well. And before we kind of even jump into back pain, you worked with me, and there's a patient that's waiting in the waiting room to come in. What do you do?
Well, generally first, I would bring them back to their room, ask them a couple questions about their history, about their medications and allergies.
So all that is actually very important. Before I even see the patient, sort of, what is the history? What are the complaints?
Absolutely.
What's going on? Then you essentially come out of the room, you let me know some of this information, and we go sort of one of two ways. Either we get some type of imaging initially in the office, or actually go in, also examine, get a little bit more history that way.
Yep.
And obviously, if there's something that has to be done or further type of tests that are needed, I generally relate to you to say, Ashley, I would need this, or we need to follow up on this, order this test, be it therapy or other imaging studies, even like CAT scan or MRIs or anything along those lines.
Yep.
So that's where you're a valuable asset in my practice. And now let's kind of go right into back pain. And if we sort of show a model here of the entire spine first to begin with, when we speak about back pain is sort of very global. And I'd like to more concentrate on really the lower back pain, which is a more common pain that patients generally have. But the spine really starts at the cervical spine all the way on top, down to the thoracic spine, and then all the way down to the lower back here. So what I like to do is actually maybe have Ashley stand up here, and I'll show you the first thing that we kind of do when we assess for back pain. So if Ashley stands right here, one of the initial things that we like to look at is, first of all, Ashley stands, just her posture. From the back, again, cervical spine is up on top, thoracic spine will be down in the middle here. That's where your ribs interact. And then your lower back is here. And most people complain of the lower back pain in this area. That's the most common, in the lower back. The main thing in the lower back when we first initially want to hear about it is it central, meaning is it in the middle? Is it to the sides of your lower back? Or something, is it in your buttocks area? Or is it more towards the tailbone? All these areas actually can mean different things of what back pain is. And not all back pain is specifically a vertebral or bony pain. A lot of it tends to be sort of muscular type of pain, but anything in sort of the buttocks area here can be really related to the posterior or the back part of your hip, like a hip strain. And that's very important to know. Is it sort of deeper in the buttocks region, or in the lower back, or is anything that makes it worse regarding motion? Even if you arch your back this way, you can have a little bit stiffness sometimes, or even if you lean forward. And once you lean forward, we can also assess the alignment of your back to look for things like scoliosis or what we call kyphosis, sort of a bigger hump. And we'll get back to a little bit more of how we look at and do the examination on it. Thank you, Ashley. I'd like to actually go to a few slides to talk a little bit about back pain, give a little bit of information on that. So let's jump right into the back pain. So back pain is a common complaint, and most people in the United States will experience some sort of back pain at some point in their life, or at least know somebody who has had back pain. So again, just to review, the cervical is the neck above, thoracic is in the middle, lumbar is the lower back, which is the most common. That's what I will concentrate on today, although I will touch about the cervical as well. And then there's sacral and the coccyx. That's really what we consider your tailbone. Those are things that are really come into effect if you really fall on your butt, if you skateboarded and just went right down on your butt. But those are really more traumatic type of injuries. Usually it's a lumbar or lower back where we concentrate on. So if you kind of just look at statistics, it's a little bit of a busy slide, but essentially it states that there is an increased prevalence of low back pain, and if you had it really in the past month or low back pain in the past 12 months, that's when patients generally seek a lot more medical attention. Former smokers actually have a higher prevalence of lower back pain compared to those who never smoked. Back pain affects about 8 out of 10 people at some point during their lifetime. Approximately 1/4 of United States adults reported having lower back pain at least for one whole day in the past 3 months. And when asked about common types of pain experienced in the past 3 months, respondents actually said the low back pain is one of the highest. Then you have things like headache and neck pain. But low back pain is really where we see a lot of the reasons why patients come to their doctor, especially the orthopedic surgeon. It doesn't necessarily mean that you'll need surgery, but that's one of the most common complaints. So what are some of the causes of back pain? Well, it could be muscle or ligament strain, it could be herniated discs, it could be arthritis, it could be some skeletal or structural irregularities, and then I'll just touch on osteoporosis as well. So if you have muscle or ligament strain, it's more of a repeated heavy lifting or a sudden awkward movement. Some people can even sleep on their back the wrong way in a twisted position, and they wake up and all of a sudden their back essentially sort of gave out. Herniated discs, that's a different type of back pain, and sometimes the back pain actually is fairly mild, but the symptoms are more towards the legs, and that could be a difference between a herniated disc, sequestered disc, or not particularly a disc bulge, which I will also show you on a model the difference between these two issues. Now, arthritis. Unfortunately, everybody as they get older gets some arthritis in their back. Unlike arthritis in their knees or hips, arthritis in the lower back can really continue without any issues. You may never seek any medical attention to it if you really haven't had any problem. But arthritis can cause some stiffness, and you may notice that you can't arch your back as much or bend forward as much. And that's really when the disc starts to dry out, you get a little bit more stiffness of the ligaments, and you lose some of that flexibility, which is also important regarding posture and some exercises, which I will mention later on, that can be helpful. Now, skeletal irregularities. Back pain can occur even if your spine curves in sort of an abnormal way. But just to make a clarification, scoliosis, which some people come in and say, well, I have scoliosis, I have back pain. Really, scoliosis in of itself does not cause back pain unless you have severe deformity, essentially like a humpback. And major curves, but not these sort of smaller curves that people say, well, I have some scoliosis, and you see a little curve in the back. That generally does not cause back pain. And then osteoporosis. The reason I kind of mention it here is that with osteoporosis, you can get what we call compression fractures of your spine, which means your spine kind of compresses down and you have a break. A lot of times these breaks don't have to be treated surgically, but that can cause pain. This is one of the areas, the most common areas, that you can get fractures in your spine as you get older. So what are some of the symptoms and types? Well, there's sciatica type of symptoms. Again, I get a lot of patients that come in, complain of sciatica. And sciatica really is pain that goes down your leg to your foot, not just in your butt area or the back part of your leg above your knee. So that's one of the most common complaints, sciatica. Low back strain. We see a lot of workers' comp injuries, people who do a lot of lifting or repetitive type of bending. Spinal stenosis, which I will also show you a little bit about that. That's actually narrowing in your spine. When you have this narrowing, it essentially puts more pressure on your nerve roots. And in the lower back, you don't have your cord anymore. You actually have just the nerve roots. Higher up in your cervical and thoracic spine, you do have the cord, which pressure on the cord can cause some significant difficulties. Compression fractures, which I mentioned before, that's more of a localized back pain. It doesn't particularly radiate, although you can have some discomfort that goes into your abdomen or your belly region. A disc herniation, that is a little bit sort of a side quote here, because that can give you more of a neurologic deficit. You have a little bit of a weakness or a numbness down in your leg. And nighttime back pain. That's actually a very important type of back pain. And what we always ask when I see patients is, does the pain wake you up at night? Do you have pain that all of a sudden you had a good night's sleep and you're sleeping through the night, but it just comes out of nowhere and wakes you up? So when you look at the on the back here, and there's an illustration on the right, it shows you a different type of disc herniations that can occur, from disc bulging to pressure on the nerve roots. And I'll also show you a model of what that means and how you put that pressure on that nerve root. Here again, the different descriptions of what a disc can look like on the left side, anywhere from arthritic discs all the way in the lower part of the spine there, to a herniated disc where it actually pushes on the nerve root as it comes out. This is an MRI imaging, we'll call an axial image on the right, and sort of a schematic diagram on the left. The MRI is a very helpful type of imaging to show soft tissues. Where X-rays show bony abnormalities, MRIs can show you these soft tissue abnormalities in the discs. And what we do is we take a look if there's pressure on the cord if it's higher up, or on the nerve roots lower down, if there's pressure on those roots that are actually coming out of the spine. Here's another MRI here showing what a normal disc looks like on the left side, and then the nerve roots illustrated here as well, and then a herniated disc with the arrows showing the black, which is the disc, which is bulging to the back. And this herniated disc can bulge further and further, putting more and more pressure on those nerve roots. And it can be central, which means in the middle, or it can be more to one side versus the other, which will give you symptoms towards one leg versus the other leg. Lumbar stenosis, again, this means it's a narrowing of your spine, which essentially indicates there's not enough room. It's almost like going from a 5-lane highway down to a 2-lane highway. So you got to kind of crowd all these cars back into 2 lanes. So the nerve roots, which are present in your lower back, now get sort of compressed together before they exit the spine and go down to your legs. And that pressure causes irritation and discomfort. A lot of people will complain of discomfort and sort of heaviness in their legs. But that is what lumbar stenosis is. And you can have stenosis anywhere in your spine, although the lower back is the most common. Compression fractures. Again, when you're osteoporotic, at the upper right side of the screen, there's actually an X-ray showing a compression fracture where the arrow illustrates sort of the flattening of the vertebral body, which is the block that form your spine. And some of these can be very significant and flatten out significantly, which can cause pain and sometimes deformity, essentially like a bend in your back where you're hunched more over. And that's more of a compression fracture. And there are some procedures that can be done for it, especially to relieve pain. It doesn't always have to be done, but there are some options that are available, which I will mention a little bit later on in the show as well. Spondylolisthesis. This is actually a slip between your vertebral bodies. And I'll illustrate a picture. I think it may be in the next slide coming up. But what it is, it's a slip between 2 of your vertebral bodies. And it's actually graded anywhere from 0, which is nothing, all the way to 5, where one body falls essentially completely off the other. And when that happens, it puts such significant strain and pull on the lower nerves that it can cause things like even paraplegia. So these are something that's important, and it can be picked up just on X-ray, but there's also some clinical facts that you can pick up just an examination regarding this. So if you look at this lady right here, what happens, we kind of sometimes consider like a bubble butt, which means that she's a thin individual. She stands up straight, but the butt kind of sticks out more than it should be. Now, some people are pleasantly plump or essentially have more of the booty call, but essentially what we look for is if you're normally physique otherwise is appear to be in the normal range, but you have sort of more of this ballooning in the back, and you say, well, I feel like I need to arch my back more, that can be an indication of spondylolisthesis or a slip between your vertebral bodies, which can be more degenerative as you grow older, but in a younger individual, that's actually more remarkable and more significant, which may have to be imaged and actually dealt with accordingly. So here in the spondylolisthesis, what happens, if you look and you see one vertebral body slip compared to the other one on the left side of the screen, the yellow is the nerve roots. Those are the nerves that go down to the legs. So as you have this slip, the nerve gets impinged or compressed between the bony structures, which now can cause that nerve not to function. If this slip is significant enough and it pulls in these nerve roots on both sides, this is where you can see significant weakness in your legs and things like paraplegia. You become essentially weak and can become wheelchair bound. So this is something important to pick up, especially if people say, I notice a difference in contour, I have to arch my back more. I do feel this symptoms going down my legs. So it's something to keep in mind, but a little bit different in the old versus the younger population. Now, what do we do when you do have a significant slip? And I'll touch more about this also regarding spine surgery. For significant slips, you have to essentially stabilize them, because if they continue to slip, they can cause neurologic difficulties. So you do have to put hardware in the back, where it includes what appears here on the x-rays. White is the metal. So there's screws and rods, which essentially holds the blocks or your vertebral bodies in position and prevents it from further slipping. You don't generally have to reduce it back to normal. You have to really just prevent it from continuation and slipping further. Now, I'll mention exercises towards the very end because exercises are very important, and most of the back pain is actually more muscular. This just illustrates a few type of exercises that can be done, but what I give patients sometimes is sort of something like this to take home that they can do on their own. It's 1 or 2 sheets of just simple exercises you don't really need anything special for to really strengthen your core area. So let's go continue here with back pain. So if you look again here at a model, and we can hone in on this a little bit. This is just your lumbar spine here. It's just 3 vertebral bodies, 1, 2, 3. And the yellow is the nerve roots that come out. And you can see at every level there is a nerve root that comes out, and each of those nerve roots will supply something in your lower legs. When people complain of sciatica, it's not one nerve root that's affected. The sciatic nerve, which is the big nerve that goes down your leg, comprises actually of several levels that come together to form a large nerve. But if you really look just at one specific nerve root, you can see that if you do have a listhesis or a slip, just like this, what happens is that you can cause this pressure on the nerve root here with this slip, and then that nerve root will stop to function and will lead to difficulties down in your lower legs. Now, what I didn't mention is something like trauma. So if you're involved in a severe motor vehicle accident and you have this significant slip like this or fractures, that causes an instability in your lower back. And this instability, shifting back and forth, can cause significant injury to the nerve roots, or even higher up in your cervical spine to your cord. So a trauma is taken a little bit in a different context, and evaluation should be really very important regarding imaging studies like x-rays initially, as well as physical examination. Because when the patient comes in essentially after the motor vehicle accident, they were fine before, but now have symptoms in their legs, some numbness or weakness, then that signifies that there's something has happened here. And a lot of times it's sort of a slip or a shift or a fracture of these elements in the back part of your spine can cause an issue on this. So if you look straight down the spine here, this is sort of the cord where the nerve roots will come out, and you can see there's only a certain amount of area that's available there. There's not that much, and as you get older, if that space kind of gets a little more crowded around the cord or nerve roots, that puts pressure on this yellow structure, which is your nerve. So that can cause some difficulty down your legs. And that's more of the spinal stenosis component, or the narrowing of the spine around your nerve roots. We're going to take a short break, and we'll come back. And what I like to do is go a little bit over a kind of a physical exam, basically what I do as an orthopedic surgeon when somebody comes in with back pain. And I'll have, once again, Ashley assist me with that, illustrating it to you. So stay tuned. I'm Dr. Amit Lahav, and we'll be right back to Your Healthcare. Welcome back to Your Healthcare, and we're speaking about back pain. I want to jump really a little bit into the examination portion of it, and then I'll jump back into the history. But for examination, I'd like to actually work with Ashley here, and since you're sitting down, that's helpful. We can begin that way. I'm going to stand up, and I want you to focus on the beauty of this program, which will be her rather than me. When individuals come in complaining really of back pain or lower back pain, what we really want to concentrate is your lower extremities. Anything up above, if you say, well, I have some discomfort in the arms, is not related to your lower back. Nothing really travels up. Things travel down. So when you're dealing with the lower back, and sometimes I have the patients just sit here either on the chair or on the examining table, and I want to first assess really what are the motion of their joints, because some hip pain can be related to back pain and vice versa. So one thing I ask them just to relax, and I take their leg like this, and I rotate back and forth. You want to make sure you have enough what we call internal rotation of the hip and then external rotation of the hip. When some people have discomfort on internal versus external, that can signify things in the hip. Things like what we call piriformis syndrome. It's a sprain in the back part of the hip. And if I resist her pushing me, rotating out, that can signify something of the tendon in the back part of the hip, which is not your back pain. But I assess that on both sides. Again, motion, really internal, external rotation. When you have limited of that motion, it can signify you have actually hip arthritis. When you lose motion in the hip, that can be related to degeneration of the hip rather than your back, and your back may be compensating for it. Next, I take a look at the motion of the knee. I want to see if they have full extension, just like that. And then maximal flexion. The chair will inhibit full flexion here, but she can move much more than this. But that's a nice smooth motion, which is non-painful. You have to look at the ankles down below. See if you can have motion, again, fully up, fully down. Now all this is passive motion. I first assess what I can make them move. Same thing on both sides here. I like to check sensation. Sensation, do you feel me touching here? Do you feel me touching here on the bottom part of the foot? That signifies specific levels in the spine. S1, which is one of the lower levels, is down at the bottom part of the foot. L5 is in the dorsum, or the upper part of the foot, and you kind of work your way up this way. And I work all my way up, all the way to the hip region, because you want to see if there's any numbness that occurs in any particular region of the leg. And that can signify really a particular level in your spine where the problem can be. The next thing is really more of the active type of physical examination. So what I do, and I generally do both legs at a time, but I'll just show you just in one here. I ask her to push against me. So push your leg hard against me. And I push back. So I first test her strength of her quadriceps here, and that can signify, again, a certain level in your lower back. Depending on her strength will depend on sort of if there is something going on. And it's essentially graded anywhere from 0, where she has no strength at all, to 5, which is actually excellent strength, and she definitely has a 5. I also ask her to bring the knee up to my hand, just like that, and that signifies more of the hip flexors, a little bit higher level as well. At the ankle here, I ask her to bring her ankle up, push against my hand. I'm trying to push it back down on her. And even the big toe, I ask her to push the big toe up, and I push against that big toe. Then I do just the reverse. I work on your hamstrings in the back. I ask her to pull the leg back, and I resist her again. And I assess the strength both sides, working all the way down to see if there's any difference between the two sides, any weakness, any pain that occurs when you have this type of examination. Some of the other things we look at like tension signs. We sometimes do it lying down, but I sometimes do it also when they're sitting up. I just take their leg, bring it up, and I just flex it higher and higher. By doing this, if there is more stress on your sciatic nerve, which comes in the back, they can become actually very uncomfortable and try to resist me. And a lot of times, symptoms in the left leg can actually relate to problems in the right side and vice versa. So I do both sides just to kind of bring, even as I'm talking to her and asking her some questions, essentially I bring it up and just see what happens when I bring it up. She's obviously not complaining of anything. She's flexible and she's completely normal. But a lot of times you can actually also assess some hamstring tightness, which means as I bring it up, she already is going to start kind of bending the knee because it's getting too tight in the back. And a lot of times it's associated with lower back pain. So when I notice that and I say, well, try to straighten it out more, and it's uncomfortable, she has to bring it back down, that's actually one of the exercises that I do recommend with low back pain to really work on stretching of the hamstrings in the back, which can also help your back. So once you assess really the sensory in your legs, the motor or the strength in your legs, I also do essentially check her reflexes. And one simple thing, you got to really have your leg hanging. I do check there, she has a little jump to it. Your reflexes, especially at the knees here, and we do upper extremities as well, but these are the most common here. We see sort of the hammer, but you can also use your karate chop right to both sides here, as you can see. Then what I do, I actually have them stand up for me. And again, what I said, turn with your back towards the camera, actually. Again, the thing is we look is alignment first and in her posture. Just her standing up like this, she looks very good. But some people will stand a little bit more like this or a little more like this. And I check again the contour, and not to be fresh or anything on this, we do have to kind of look at the butt when we examine the back because it's all connected. And again, if you have sort of more of a significant curvature going out this way, that can signify things like spondylolisthesis or slip that can occur. The next thing is, I ask her, well, how about we arch your back? And she arches back, and she's pretty flexible, but I want to see if she's uncomfortable and how far can she go. And then I ask her to really lean forward, and we're not going to go all the way here, but I want to see if she's flexible enough and comfortable to really go down. If you have a lot of tightness in your hamstrings in the back, what happens is that you'll start kind of bending your knees. Now, some people are not very flexible, but I want to know if it's associated with discomfort or any pain. I bring it back up this way. I also like to see how she leans side to side. So is it symmetric, going one side versus going to the other side? The other thing is, again, upper posture here, how she actually holds her head above her lower back altogether. And when she bent forward, I just take a look at the alignment of your spine. That can illustrate things like scoliosis or some curvature. And we get a lot of sort of high school individuals, more common in girls, to check if they have scoliosis. The pediatrician sometimes brings them over to say, well, just want to make sure that there's no curvature that's going on. And that's sort of a very easy exam to do. And you really look at the levels also of your shoulder blade. If you do have scoliosis and leaning forward, you're going to see sort of one side of your back higher than the other side. And that, again, that can signify a little bit regarding a curvature of your spine. One thing that I also like to do is when she stands, I actually take my hands on the shoulders and I push down. by pushing down, I'm causing more pressure on the lower back, and some people have discomfort with that, and that can signify something going on. And next is really palpation. Again, I want to know, where is the pain? Is the pain centrally here? Is the pain more to one side, here, or here? Or is it more into the buttocks area here? And you do go actually and push into the buttocks, into what we call the sciatic notch, which means that the sciatic nerve, that big nerve that comes out of your back, actually is in your butt area. And you have to go right into this area and push deeper into it. And some people do have discomfort in that region. But the most common back pain is really here, on the sides here. Not centrally, more to either side. And that's actually not where the spine is. The spine is in the center. And that's more of what we consider mechanical low back pain for both sides. Thank you, Ashley. And that's sort of just what I look for when I examine back pain. And again, the most common back pain is really what I consider mechanical back pain. And even if I give you just some statistics on it, about 50% of patients who initially have back pain without a trauma or neurologic symptoms down the legs, 50% of those patients would get better in 6 weeks without doing anything. You didn't see a doctor, you just waited out. 50% would still get better on their own. If you actually look at 3 months down the line, about 80 to 90% of patients, again, will get better on their own without doing anything particular. The only issue is that it's a chunk of time. 6 weeks, 3 months, it can take you out of commission for a little while. So what we try to do is we try to kind of facilitate that and move you forward. And if you look at really the American Academy of Orthopedic Surgeons, really for just a back pain, again, non-traumatic, without neurologic symptoms down below, X-rays are generally not recommended for the initial 6 weeks. Now, a lot of us actually speed some of that up because we do pick up things on X-ray which can signify different issues, and also we want to make sure that things are normal. There's nothing else going on. But really, by the Academy, they say you can wait 6 weeks on it. The only issue with that is if you tell me that you have night pain. If your back pain wakes you up at night from a sound sleep, not functional, not when you're lifting or moving, but really night pain, especially if you have things even like night sweats or fevers, that sometimes can signify things like tumor or infection in your spine, what we call discitis, or some osteomyelitis. And those are very key questions that we ask when somebody comes in. Not just the back pain, when is it? Night versus day. If it's mechanical, which means it hurts when you do something, or just even if you're sitting down or lying down, you have that pain. Because in the older individual with back pain, you have to consider a tumor as one of the cause. And in the older individual, a lot of times it's either metastatic or things like multiple myeloma. Those are sort of the top two that we consider. So that specific question is essential when we take the history. And Ashley also, asks some of these questions for the individual because it's important to get that when she comes out of the room and tells me, Dr. Lahav, they have some back pain, they've had it for 3 months, it's not any better, but it wakes them up at night. And that sort of raises an eyebrow and say, well, why don't we get an X-ray? That's one of the individual you don't want to really wait on. We have to assess it. If there was a trauma, again, it's something that I do get an X-ray because there are certain subtleties that we can pick up an X-ray that can essentially show me that something has gone wrong or something has happened. And family history. If you have a lot of family history of back pain or medical issues, that's important to know. What have you done for the back pain? Do you take anything? Do you have taken any medications? Are you on steroids, for instance? Is it a work-related injury? Most individuals who have back pain once in their life and it begins to be recurrent, which means you have it every once in a while, you actually start to have a higher and higher chance of having more we call chronic back pain, which means that it's not going to go away. It persists. Even if we do a full examination, a full workup, and there's really nothing particularly structurally wrong, a lot of it is subjective. You're going to have some discomfort, unfortunately, longer in life because you've had some of these episodes of back pain. So once you start having something, it is important to try to treat it. And one of the things that I always like to do is work towards the exercise. I tend to be a little more conservative on what I do. I give exercises like I showed it before in some of the slides of some simple things you could do at home. Sometimes I augment it with formal physical therapy, or I do use sometimes some chiropractic treatment. And there's some caveats of what I do like and what I don't like, and I discuss that with a patient when I see them. But different modalities, sometimes medical acupuncture or deep tissue techniques can be very helpful as well. And that's, again, for the more common soft tissue or mechanical back pain, like a back sprain. Some people like to use a back brace, and what I say is generally that's good. If you feel better wearing a back brace, then it's worthwhile. If it makes you uncomfortable, then you shouldn't be doing it. If you are lifting a lot more, then you really should have some sort of support for the lower back. But really to strengthen your core, which is your abdominal and your lower back, your belly here and your lower back, they are both important for really in the integrity of your lower back. Not just working on the lower back region, but also on your abdomen and posture and physique. And all that I kind of take into account when I talk to the individual. Anti-inflammatories can be very helpful, some over-the-counter, things like Advil, Aleve, Motrin, ibuprofen. And there are some that are prescription ones, which you only have to take essentially one a day. But you have to discuss also the risks regarding stomach irritation, as well as some sensitivities if you're on blood thinners, in addition to what's important, again, the past medical history, as well as the medications and any allergies you may have. And that actually will give you a little segue to talking about topical pain management, which can also be assisted for your relief in back pain. So we'll take a very short break and we'll kind of jump over to something else that is actually topical pain management. Stay tuned. We'll be right back. Welcome back to Your Healthcare. I'm Dr. Amit Lahav, and we're going to actually jump from back pain more to topical pain management. And this is something that I've actually been involved in for many years, initially in the kind of the infancy of topical pain management rather than using oral type of medication, be it narcotics, anti-inflammatory, acetaminophen, things like that. Topical to me means you put it at the area where it's uncomfortable. When you take it orally, it goes systemic, it goes everywhere. But some of these topical things, you just treat it at the area, be it your lower back, your ankle, your knee, your shoulder, and it really stays more at that local region, so you have less systemic effect. You absorb less into your body. And this has sort of come out through the woodwork, especially over the past 2-3 years, where a lot of companies kind of been going into compounding type of medications. And I've been through this sort of in my career, and I kind of stayed more with one company versus another for multiple reasons. But the compounding, meaning you can use multiple medication at once rather than taking it all orally. And I like to kind of give a very nice overview of just the topical type of management. If we can go to the presentation, please. So we're going to talk about pain. And again, that's one of the main reasons why I have patients come in, and it's pain. So some pain is self-inflicted, which is not what we're going to talk about. We're going to talk about the pain that is not self-inflicted. There are certain things that are pretty obvious. Don't sit on the fence when there's spikes on it and there is water on the road when it rains. That's kind of the obvious thing. But what's not obvious? Well, pain is not obvious. It's not straightforward. You have to figure out what it is. Is it subjective or is it something objective, meaning something is actually causing you pain? So certain things are really coming at your face. It's pretty obvious as you walk through the door and I can tell you something is wrong. But pain treatment is not. And why do I consider transdermal treatment rather than sometimes oral treatment? Well, we'll go through this because sometimes pain hits you in the face and it hurts and it comes right at you. So when acute pain occurs, it can lead over time to chronic pain. Now, what happens with chronic pain? It can affect you personally, it can affect your family, you can't cope with it. There could be increased pain over time, anxiety, depression, affect your work. So what we try to do is we try to make you feel more comfortable, and then it treats everything all at once. So the thing is, pain is not very flexible. And although I had Ashley here, and she actually appeared very flexible too, and maybe she'd be able to do something like this as well, maybe at one of my next shows, pain is not flexible. So what do? Well, we have to determine where do we go on here? This painless and painful, where are you sort of in this spectrum, and how can we get you over to the left rather than the right? Well, a lot of times many doctors do use narcotics, and I see it a lot from primary care physicians where the patients come in with pain and they are on narcotics. Now, the issue with narcotics that I always tell patients, narcotics does not treat the underlying problem. Narcotics will mask the pain, and then the pain still persists. Now, I'm not talking about narcotics in the lower part of the screen like marijuana and things like that, although there is some medical indications for that as well, and I do not store this in my office. But there is a part of medicine that does relate to some of these other things in the lower part of the screen. But I'll stay really more the narcotics medication-wise that are in the upper part of the screen. We see a lot of studies, and it's kind of a busy slide, but essentially it indicates that opioids and narcotics can cause deaths. So why do I consider transdermal pain solution? Well, it's because you don't take it systemically. You can treat it focally or locally or regionally rather than systemically. And you just have to really consider what you're looking at and give an option. The sun will always rise in the background. You just have to pay attention and go for it. So transdermal delivery of medication is actually not a new concept. It's been around for decades, all the way back from when you had maybe even your grandma, your grandpa told you about. They concoct something on there and slop it on your back or on your thigh if you had a wound, and it works, whatever it may be, different plants, grains. There's all these homeopathic type of remedies. But you know what? Some of it has worked, and even different type of peppers like capsaicin has been used. It's sort of given a burning sensation. So it's been around for a long time, and now we're sort of realizing, well, maybe we can use some other medications also topically with what's been around for decades. So can it be a possible first choice of therapy? And the answer is yes, even before you consider things like narcotics or opioids or anti-inflammatory medications. And you can also use it when other medications have failed. So you can't just say, well, we're done here. This is something to consider that's sort of out-of-the-box thinking. We're not talking about injuries as shown here. Now, again, I'm an orthopedic, so we got to show some type of more gross type of pictures. But these are obviously fractures or significant dislocations. You can slop anything you want on this, but it obviously needs more urgent treatment by an orthopedic surgeon. Things like this also, it could be a more soft tissue injury to the jewels of your family there. Although I'll mention that there is actually some topical treatments that are given for vulvodynia in females. That's the private vagina area, as well as Peyronie's disease, which is essentially an erection that doesn't go down. Now, I'm in orthopedics, and we're not going to touch upon that, but there are some topical treatments for that as well. So what am I talking about? Well, I'm going more towards the overuse type of symptoms. And that's really where I consider more of topical treatment. You know, a lot of individuals are pretty active. You know, they walk, they run, they play tennis, they play golf, they want to be active. And sometimes you get some soreness and achiness from being this active. Lower back, as I mentioned the first part of the show, is very common. Lower back is a common complaint. And you don't always have to take things that are oral. You can take things and use things that are topical. And some can come in a gel, in a cream, and there are some also that come in patches. So transdermal therapy is something I use for what we call myofascial pain, which is soft tissue type of pain, muscle sprains, bursitis, tendinitis, things like that. And I just have a little list here of some of the diagnosis that I do consider some topical treatments. There was actually a study looked at 3,600 individuals who suffered from pain. And this is just general pain, and they used something topical, and more than 83% of them reported significant reduction with the compounded creams, not using things orally, using these type of creams, which is a big deal. To me, that means that there is a chance that you can do better without taking things orally, without having the side effects of taking some of these medications orally. So what about some of the standard therapy? You know, as an orthopedic surgeon, we use a lot of anti-inflammatory medications, even Tylenol. The problem with it is not particularly the addiction, but a little bit more of the stomach irritation or the liver irritation, or the effect it can be on the kidneys. Or individuals that are on blood thinner type medications. You really can't keep taking some of these anti-inflammatory medications on top of that. It can lead to bleeding. So again, I'm just illustrating here that death in the United States, really, just from anti-inflammatory medications is above 16,000. Opioids, tremendous amount of number. Tylenol, acetaminophen, a little bit lower. But really, due to a transdermal treatment, really there hasn't been any death related to transdermal creams. So that kind of raised an eyebrows, well, is it for me? Well, the CDC also looked at some of these statistics, and again, a lot of these deaths that occur is due to pharmaceutical drugs. A lot of them are narcotics, oxycodone, hydrocodone, methadone. These are things that I generally tell patients sort of a dead-end road. You know, we can do it, but you have to remember, I'd like to really try to treat the underlying problem and to figure out if we can do something about it. So transdermal therapy to me is an alternative, and it's a good alternative for the right individual, for the right reason, and at the right time. And why is it? Because it treats both what we consider the immune and the neurologic component. Pain is actually multimodal. It's not just one thing that causes it. It occurs for different reasons. And to just show an illustration is, if you just make an incision or a laceration or a cut in your skin, the nerve endings there is what gives you sort of that pain. So the pain begins. And what happens is immune modulators from local tissues that sort of react to this type of trauma or this type of injury. And what happens is that you go down what we consider the arachidonic acid pathway. That's sort of getting a little more complex maybe and more scientific, but this is really the pathway that most current treatment, oral treatment, anti-inflammatory treatment addresses, but it only addresses one type of pathways. Because there's actually two pathways. There's the cyclooxygenation, what we call the COX, and the LOX. So essentially what I want to say is that there's a lot of different reasons why you have pain. So what happens, you get more sensitizing of the sensory nerves and your pain threshold drops down. And when the pain threshold drops down, it leads more to sensory, really with of pain with no or little input. So even like a light touch can cause discomfort, more pressure can cause discomfort. So now you're sort of sensitized in the region. So what do we do? Well, we can use some oral things like diclofenac is one of the oral medications, things again, Motrin, Advil, but we can also use it topically. So essentially you rub it in the area where it bothers you. And that goes down again more the COX pathway. But not only that, we have those two pathways, COX and LOX. LOX is not what you put in a bagel. It's what we call leukotriene. COX is a cyclooxygenase. And what we don't want to forget is there's other receptors. It's not just taking the anti-inflammatory component. There's other reasons why you can have pain. So transdermal therapy here will address all those. And the difference from one side to the other is, here's one of my patients on the left compared to not my patient on the right. And when you have a happy patient on the left there, that's really what matters. If the patient is happy, then we've done the right thing. If the patient is unhappy and they have pain, that what brings them back more and more to the doctor, and they're unhappy about it. So what we do is we try to treat all these multiple targets that cause the pain, and this is what the topical treatment is. One of them is an anti-inflammatory medication, which is called diclofenac. It's the most common one used in most of the creams that are out there, and that is something like you do take orally, but we treat it with topically. there's now other type of medications we can use. We treat the NMDA receptor. That's one of the main pain receptors. And some of these medications, when you take orally, can cause dizziness, a little confusion, lightheadedness. But now when you take it orally, it's a very small amount and acting locally. There are some calcium channel blockers, which can also be used. And again, these are just different medications which can be treated locally in the region to decrease the pain. Some of these medications that we also add to it at higher level, they're actually psychiatric medications. But at a very low level, they can be used to treat pain. Some muscle relaxants as well. So there's a lot of different type of medications that I'm illustrating here that we can kind of put all together into a cream base. Here again, I'm showing just a muscle relaxant. So there's a lot of these medications. And what happens when we put it locally, it can increase that threshold for firing and increases the threshold for pain, and thereby decreasing your symptoms of pain, which makes you more comfortable and, again, happier. And how do we deliver it? There's different delivery systems that we do that have to penetrate the skin. So all these medications are kind of placed in some type of delivery agent that will help penetrate the skin, take you through the skin, and then essentially release all these medications down below the skin level and even deeper. And you can deliver 24 to 50 times more medication locally than when you do orally. Now, I'll repeat it, 24 to 50 times more locally than when you do take these orally. And only about 2 to 15% of it can be found really in your blood, which means that when you take things orally, 100% will be found in your blood. But when you do things topically and locally, a very small amount gets absorbed really into your systemic system. So it's really being treated more locally, and that's really where the pain is. I want to treat it locally. Again, just showing some of the list of things that I consider for some of the pain regimen or topical type of treatment. And this is one of the questions I guess, that the smell. Is there an odor to it? Because there are certain things over the counter that I have individuals come say, I put it on, nobody in my family wants to be next to me for like 3 hours. Well, a lot of these actually have no odor, no smell. You just put it on and it actually can be very helpful. And this transdermal therapy can really offer a sophisticated receptor-based therapy with a large margin of safety, which is what I sometimes discuss with my patients. Now you got to consider the anatomy. Obviously you don't want to slop it on everything. This is unfortunately not a picture of me when I was working out, but it's, I like to say, somewhat close. You can slop anything you want on some of these, but to penetrate these deep muscles, it may not work for these specific individuals. What I'm just showing here is the prescribing pain medications. Orthopedic surgery ends up being somewhere on top there, along with internal medicine and sports medicine as well. So I see a lot of it. And is there really a leap of faith about it? Well, there shouldn't be really a leap of faith because it's treating your pain. It's an option. I give you another solution that can be out there, and it's worth a try because pain can be treated. And pain is inevitable, but suffering is optional. So that's when I consider things like transdermal treatment. So we come back to us here, and what I really wanted to say again is this is just another option that I also sometimes use on back, and there are different also patches that can be used in the back, not just cream and certain gels, but they are prescription based. You can't just go to the pharmacy and get some of these. There's a lot of stuff on the counter, but what I'm dealing with is things that have been around for a long time. A lot of these medications that we put into these sort of type of creams and gels have been around for a long time and have a good history, but we just essentially treat it now locally. And I've had some good results and effects, and if patients are happy, that's what it's all about. It's about your health care. Stay tuned, and we'll be right back to sum up today's show.
Well, I guess I've been told 1,000 times before. Yes, I guess I've been told 1,000 times before. Never be weak for a woman. If so, never let her know. Yeah.
Welcome back. I'm Dr. Amit Lahav, and this is Your Healthcare. In today's show, we spoke about back pain. We've had Ashley here able to assist me in demonstrating to you what I look for as an orthopedic surgeon regarding back pain. Some of the history, some of the anatomy, physical examination, and what we do really in my office when we see an individual for back pain. We also jumped over to topical pain management, and I sort of gave you I think very general overview of what is out there and what's available really to you. And again, what I like to say is the more you know, the better it is and easier for you to make a decision really about your health care. From back pain to topical pain management, I'm Dr. Amit Lahav. Thank you for watching our show. This is Your Healthcare, and we'll see you next time.